반갑습니다. 저는 한국한의학연구원 이명수라고 합니다. 예. 주말에 이렇게 지금 오늘 서울 날씨가 영하로 떨어졌다는데 어려운 걸음 해주셔서 정말 감사합니다. 이 구슬이 우리나라 속담에 이제 구슬이 서말이라도 깨어야 보배라는 말 속담이 있는데요. 오늘 여러분이 오신 거는 여러분들이 만드신 그 연구 결과를 구슬이라 생각하시고 초대한 연자분들이 깰 수 있는 기술이라든지 노하우를 전수하는 시간을 여러분에게 드리고자 합니다. 그래서 잘 아시는 KM 분야에서 이제 SCI 저널이 두 개가 있는데요. Complementary Therapy Medicine하고 Journal of Alternative and Complementary Medicine이 대표적인 것이 있습니다. 그 중에 하나인 Complementary Therapy Medicine의 로버트 반 하셀렌 박사와 유로피안 저널 오브 SCIE인데요. 유로피안 저널 오브 인테그레이티브 메디신의 니콜라 로빈슨 교수를 모시고 한의학 환자 보고 케이스 리포팅하는 방법이 이제 사실은 이 모든 연구에서 시작인데요. 그 리포팅하는 방법에 대해서 설명해 주시고, 그리고 니콜라 로빈슨 교수는 논문들이 서미션 하면서부터 출간되기까지의 과정을 보여주면서 그 중에서 이제 어떻게 해서 성공적으로 논문을 출간할 수 있을지를 알려드리도록 하겠습니다. 그리고 경희대학 박희준 교수님께서 실험 논문 전략, 출간 전략, 그리고 부산대학교 신명철 교수님이 임상연구 논문 출간 전략, 그리고 경희대 김태형 교수님의 이제 SCI 논문을 쓰면서 본인이 경험했던 것들을 바탕으로 해서 여러분들에게 알려줄 수 있는 노하우를 알려드리도록 하겠습니다. 저는 간단한 논문을 출간할 때 여러분들이 팁을 가질 수 있는 것을 정리해 보았습니다. 근데 강의를 듣다 보면은 사실 많은 부분이 중복이 되거든요. 근데 중복되는 것이, 중복이라는 사실은 그만큼 그 부분은 중요하다고 생각을 하시고 좀 더 지루하실 수도 있겠지만 잘 들어주시기 바랍니다. 우리 바쁘신 마지막으로 이제 바쁘신 와중에 이제 함께 해주신 여러분께 감사드리고, 사실 이것을 준비하기 위해서 많은 노력을 해준 스태프들이 있습니다. 그분들을 위해서 한번 박수 한번 쳐주시면 감사하겠습니다. 그러면 먼저 로버트 반 하셀렌 박사를 모시고 케이스 리포팅에 대한 것을 듣도록 하겠습니다. 박수로 맞이해 주시기 바랍니다.
Well, good morning, and it's a pleasure for me to be here in Korea, and I would like to thank Kiam very much for the invitation to speak here. It was my first visit to Korea, and I'm really very wonderfully surprised by the wonderful reception, the hospitality, the kindness, the wonderful food, and also of course, the wonderful and good quality science in Korea. But no, it's truly a pleasure to be here, and I hope to share with you this morning a topic on which I've been working for the last 6-7 years from a scientific perspective, and I believe it's a topic that has somehow been neglected a bit by medicine, or neglected a bit by evidence-based medicine, and I'm now in the process, personally at least, to try and raise the topic of clinical case reporting in the complementary medicine scientific community. I've given several lectures in Europe on this topic. I gave a seminar in May in India on this topic with homeopathic community. Now I'm in Seoul, and next week I'll be continuing for China, also talking about this very important topic. At least I hope that by the end of the morning what would stick with you is the importance of clinical case reports and their role in medicine, And in a way, the contribution that clinical case reports can make to the evidence base of medicine, traditional medicine systems, and last but not least, in fact, the contribution that each of you, each clinician, each practitioner can make to medicine by applying some of these principles which I hope to share with you. So just a program for this morning. I will start by saying something about the role of clinical case reports in medicine in general. Then I'll say something about case reporting guidelines, because this is the theme of the day is of course the publication of your work, and so a running theme of course will also be how do you publish and write up high quality case reports. But the actual theme will be broader than just the publication part, but it's definitely the red thread. Then I'll say something about reporting guidelines, and in particular also a project in which I've been involved where there are specific guidelines or tailored guidelines which are tailored to the specific complementary and alternative medicine discipline. And I've been personally involved in the development of a homeopathic guideline, case reporting guideline, and it's my personal vision that for traditional Korean medicine that could also be an extension of a reporting guideline for traditional Chinese medicine. So the real vision is to also foster the development of guidelines which really are also tailored to the specific therapeutic discipline. And then we'll do a practical exercise. You'll find a case in your folder. So we will basically analyze a case. We will apply the case reporting guideline just to give people a flavor of what this will look like. And then I'll complete the session in the morning with some presentation about critical thinking and how critical thinking is relevant, not just for scientists but also for clinicians. And I will talk a little bit about the relevance and implications for critical thinking, in particular, of course, for as it applies to clinical case reports. But it will take us through a very short journey through not just epidemiology, because that's something what you would expect at a scientific conference, but it will take us through some aspects of psychology as well, in terms of human decision making. So we will enter a little bit in that. We will just touch the surface, but I hope to give you enough awareness by the end of the morning about how important this actually is. And of course I will complete the session with an outlook and some conclusions. Well, I think the Dalai Lama said is we must conduct research, then accept the results, and if they don't stand up to experimentation, the Dalai Lama stated that even the Buddha's own words would need to be rejected. So this is in essence critical thinking. This is in essence scientific thinking, and it's quite remarkable that the Buddhist philosophy is so compatible. In fact, it was Einstein who commented that probably of all religions he felt that Buddhism was most compatible with scientific thinking. But what's quite important is we must also, I think the reason why I wanted to show this is that the Dalai Lama goes as far as stating that even if it's your own religion, even if it's your own beliefs, even if they are your own prior beliefs, which are being challenged by the facts, we need to have the courage and the openness to change our views. And that's the essence of scientific thinking, but that's not always easy. As I will also illustrate, there's a lot of mechanisms which will either prevent us or make us reluctant to change our views. So about myself, I trained in homeopathy and epidemiology. So I have my legs in one leg in a very conventional scientific training, and another leg of my I have training in homeopathy and natural medicine. During I've practiced, but I've left my practice for about 25 years ago now. So for the past 25 years I've been dedicating my career to fostering high quality research in the area of homeopathy and other natural medicine systems. I've worked inside the homeopathic pharmaceutical industry, where I set up research program, clinical and preclinical research programs. I've also worked for 8 years for the Royal London Homeopathic Hospital, where we were involved in the public sector to investigate some of the services that were provided there. Then, a little bit over a decade ago, founded an institute, which is INTMEDI, the International Institute for Integrated Medicine. And for the past decade, I've been editor-in-chief of Complementary Therapies in Medicine, which is one of the leading peer-reviewed, dedicated CAM journals. And I'm also very pleased to regularly publish papers from Korea, good quality and high quality papers. So yes, that's. But it is the Complementary Therapies in Medicine is the green journal, because you have various colors. You have a blue one, you have a green one, and Complementary Therapies in Medicine is the green one. Now it gives me, in a way, particular pleasure to talk about this topic and talk about this topic of clinical case reporting, because in a way it reflects the journey, my own journey through the past 25 to 30 years, where you start in practice, but when I started in practice I felt that conceptually, like the natural therapies and the traditional medicines were very elegant, but I felt that the empirical base was weak in many cases. And so then I studied science. So I moved away from practice, as I said, and I went into the real business of scientific research, setting up randomized controlled trials, trying to get the most rigorous types of studies going, and so that's really occupied me for 15 to 20 years. But then, as I mentioned, for the last 6-7 years, I've been looking again at this topic of clinical case reports. And so in a way, and what I'm presenting today is a reflection of that journey, and it's in a way, yeah, is there a pointer somewhere? Or? Okay. In a way, it's a reflection of starting in practice, then going on to a journey where I'm moving out of practice and really very much into the scientific domain, and then with that experience, with that baggage, with my suitcase, with some knowledge and maybe useful and less useful knowledge, look again at this aspect of practice. And so it's, for me, it's a bit like, it feels like completing a cycle in my own career. And so I hope to share some of that with you. Yeah. Yeah. Okay. All right, so clinical case reports. It has been said about clinical case reports that every person and every case can teach us something. And that's definitely the motto. Now, actually, case reports, the first case reports dates from 1550 before Christ. And it was on one of the surgical papyrus. If there's anybody in the room who can translate this, then please let me know. But I thought maybe that person is not in the room. So the translation is basically that if someone has a dislocated mandibula, then you do the procedure. He cannot open and close his mouth. Then you do the procedure where you place your thumb and then you make this movement to reposition the mandibula again back into the correct place. So arguably this is the very first case report in the history of medicine. So it's quite clear that case reports is, in a way, if you look at the scientific evolution of medicine, it all started there. I have to mention, in terms of clinical case reports, I have to mention M Jenicek. And because he published his book, I believe, in 1999. And it had the title Clinical Case Reporting in Evidence-Based Medicine. Now, that doesn't really sound very remarkable, but what we have to realize is that this was the era where in the early 1990s the whole movement of evidence-based medicine was gaining momentum, and evidence hierarchies were actively promoted. And in those evidence hierarchies, the vision of evidence-based medicine is, in some ways, the way some people interpreted it, even though it's not the real evidence-based medicine is broader, as I explained in my lecture on Tuesday. But as some people interpreted it, is that let's take the anecdotal data out of evidence-based medicine and move to the more reliable scientific data as a basis for evidence-based medicine. And so here is this professor of epidemiology who actually wrote a whole book on this topic at an era where people were not interested at all in clinical case reports. Every evidence hierarchy you would see, you see the pyramids, and it was always systematic reviews of randomized controlled trials and randomized controlled trials at the top, and you stay somewhere at the very, very, very bottom of the pyramid, and this is where you then would find, well, expert opinion, clinical cases. So I have to give credit to Miles as a professor of epidemiology despite this, write a whole book about it. And when I started looking into this topic of clinical case reports, that's about 7 years ago now, I started by organizing a workshop where I got several experts together, and I also had the pleasure to invite Miles Jenicek, and he's an absolutely adorable man, a very humble man. I mean, if you read his titles, he's an extremely knowledgeable person, but an extremely humble person at the same time. So I'm standing on his shoulders in many ways. Now, what Miles Jenicek did in this book is what, in a way, every good scientist should do before he engages in any kind of project, and that is defining your objectives. And because Miles Jenicek thought more deeply about the role of clinical case reports in evidence-based medicine, than any other person at that time, he actually managed to come up with 37 reasons, 37 different objectives to write up clinical case reports. Now, I'm not going to explain all the 37 reports reasons to you, but there are clusters of reasons for doing case reports. And of course, the one that anybody who's gone through medical training is familiar with is, of course, it's for teaching purposes. And on the one hand, for teaching purposes, you would want to talk about usual cases. In other words, you need to know, okay, if it's an appendicitis, what are you going to see? What are the main symptoms? So the usual cases. But of course, the role for wanting to write up a case report is often also unusual cases, because unusual cases, of course, can provide very useful teaching, fulfill useful teaching objectives. But also a reason to put attention to clinical case reports could be clinical failures and errors, and this is of course something which Milas understood, that it's not about just successes, it's about also learning from the failures and even learning from your errors. And in some cases, sometimes you can learn more even from your failures than from your successes. So that's one cluster of objectives, and the other is for research purposes. Now, one aspect is, for instance, that a case can generate hypotheses, and many discoveries in medicine are triggered by clinicians in their practice, because they make particular observations in their practice, and that gives them an idea, it generates an hypothesis that then can be verified or also falsified. But clinical case reports are a very important tool for hypothesis generation. And the other aspect is, of course, that once there is some knowledge or knowledge assumed to be present, the case reports can be used to validate or confirm knowledge. Like, for instance, in the area of homeopathy, where I'm more familiar with, is you're doing some sort of kind of phase 1 clinical trial where you give substances to healthy subjects, and then you very carefully write down all the symptoms they develop. And then the theory of homeopathy says that if you treat patients with similar symptoms, then finding the correct homeopathic medicine means finding the medicine that will cause similar symptoms as the symptoms manifest in the patient. And so, if you've done one of these phase 1 trials, which are called provings, homeopathic drug provings in homeopathy, a first step that Hahnemann, who's the founder of homeopathy, would have taken, he would have started to confirm some of this information on the basis of clinical cases. And last, and definitely not but least, there's the aspect of adverse events. And this is an area where also, in particular within conventional medicine, case reports are widely recognized as sources of information for possible safety problems with particular medicines. I mean, we all know there's many examples that conventional medicines, some conventional medicines have gone through a whole trial of a drug development program, including clinical trials, but some rare events, some very rare but very severe events simply were not manifested in clinical trials simply because there were not enough subjects in the trials, or because maybe the subjects that were in the clinical trials were not representative of the patients treated in real practice. So that's where, again, case reports can provide a very, very useful and valuable source of information. So, where does that put us at the moment? Is that case reports are widely and increasingly published in medicine, but until recently there was no clinical case reporting guideline. Now that is in a way quite surprising, because we know that the guideline, reporting guideline development has been an enormous wave of activity in evidence-based medicine over the last 20 years, and it goes from PRISMA, the Consort guideline for qualitative research, you name it. I mean, if you go onto the Equator website, which is a website which collects all the reporting guidelines, you will find an enormous range of reporting guidelines, but actually until recently there was no clinical case reporting guideline. And I think, as I mentioned, it reflects and represents a little bit the way clinical case reports have been neglected in evidence-based medicine, have been a bit left to the side, because it was simply considered so much at the bottom of the hierarchy that it was not deemed a priority to pay attention to. Now, if we look in the area of complementary and traditional medicine, it's been a fairly consistent pattern, because case reports there have been and still are considered to be very important, both for teaching and research purposes. And only recently, in September 2013, the CARE guideline, which is the guideline on the reporting of clinical cases, was published. In fact, I initiated my first workshop, which I refer to, that was in 2009, and I invited the experts to that workshop, and actually including Professor M Jenicek, as I refer to, but one of the experts who participated in that original workshop went on to develop the CARE clinical case reporting guideline. So this first workshop 8-9 years ago triggered actually the development of this reporting guideline. And what I have been personally involved in for the last 4 to 5 years is, in addition to this general CARE guideline, because the CARE guideline, which I will explain to you, which you will also work with in the morning as an exercise, the CARE guideline is a generic guideline, something that applies to all clinical cases in medicine. And my objective was also to set out and develop specific items for case reports, in this case in homeopathy, leading to effectively an extension of the CARE guideline, in which some specific homeopathic items have been identified. And what's quite clear to me, that the lessons that I have learned in this domain of homeopathy apply to traditional Korean medicine, apply to traditional Chinese medicine, and that's why also it was quite interesting that when I mentioned to Professor Jiangping Liu, who's also associate editor of my journal, Complementary Therapies in Medicine, that I said, well, I've been working on this topic, and then he said, oh wow, I've been thinking about this topic for many years. I've been thinking about the importance of this topic in the area of traditional Chinese medicine, how to advance it. And in fact, my visit to China next week is also a result of that initial interaction, where he said, look, there is a real relationship here, and there's a real relevance, not just for homeopathy, but for traditional medicine systems as well. Okay, so that's a brief introduction. Are there any questions or comments at this point in time? Good. So, don't worry, you'll have plenty of questions when you come out of this morning session. I can guarantee you that. You'll have more questions than you entered the room with, but that's a good thing. That's my objective, that you have more questions. Obviously from behind, at the back you cannot read this, but there is the checklist is in there. And so this is the care checklist. So there are a number of items, reporting items, and we will go in more detail into this checklist. But essentially, it breaks down a clinical case report into a number of topics: title, keyword, abstract, introduction, patient information, clinical findings, timeline, diagnostic assessment, therapeutic intervention, and then follow-up and outcome. So it's breaking down the architecture of a clinical case report in its main component, and then of each of these components there's a number of guideline items that have been formulated. So we will go deeper into these items when we go into the practical exercise a little bit later on. Now, so when I engaged and started engaging in this project, the vision and the goal was obviously to improve the quality of case reports. And I don't know what the status is in traditional Korean medicine, but definitely in homeopathy, where I'm more familiar with, my general feeling was that the quality of case reports was not very high, and often clinical case reports were just fairly brief, and there were always cases of successes, of course, so my general feeling was that the quality wasn't very high. And in fact, when I did this first workshop in India, in Delhi in May, to prepare, I went through the whole homeopathic literature because I thought, well, I wanted to find a case that we could use in the workshop. And I started looking into the literature, and I had very big difficulties to find some suitable cases which I felt would be good enough to use. And when I asked the same question to Min So to prepare for this lecture today, I said, well, can you send me some clinical case reports? I got a very quick reply, and I got 10 wonderful PDFs of 10 case reports. So I was very pleasantly surprised that I think in Korea there's already a movement in this direction of wanting to raise higher standards. So that made actually the preparation for this lectures this morning a lot easier for me, because I was in a luxurious position to say, well, what case shall I select just for this morning? But so the vision is really to further lay a scientific foundation for and develop a reporting guideline for high quality clinical case reports. And in particular, to improve the reliability and value of CAM, Complementary and Alternative Medicine clinical case reports in general. And of course, to promote transparency, because I think we've had some discussions at various meetings over the last few days, and I think one of the things which I've always emphasized in discussions is transparency. For me, one of the lessons I've learned, science is about being transparent. It's about saying, well, this is my reasoning, this is my opinion, these are my assumptions, this is how I reach my opinion, And of course people can disagree. People can say, oh, it's totally wrong what you say. But the whole idea is that you develop a platform of transparency on the basis of which you can have a meaningful discussion. And of course a reporting guideline is an absolutely essential tool in achieving that kind of transparency. So when I embarked on this project for the area of complementary medicine, I simply I started by writing an overview paper, and what we did during that very first workshop, we said, well, Professor Jenicek formulated like 35 objectives for clinical case reports, but which ones are the most relevant in the field of complementary and traditional medicine? So we had a brainstorm session, and so we tried to assess in terms of the objectives of clinical case reports, which ones are the most likely to be most relevant in the field of complementary and alternative medicine. And so it just to help us starting to focus the project. And so that resulted in a paper which is in here, which I wrote, and it says, towards improving the reporting quality of clinical case reports in complementary medicine, is assessing and illustrating the need for guideline development. So in this paper you will find a lot of the ideas and the background ideas that provided the basis for the actual guideline development. Now again, I won't go into the detail, and in your handout I have this one slide where we defined, at least in this expert group, the main CAM relevant objectives for clinical case reporting, and I hope you can read it in your handout, but you can find this in the article as well, so you can always look that up. But for instance, one example is that an objective is a clinical situation of an experience that can be reproduced for ethical reasons. And some of the first clinical case reporting initiatives were in the domain of cancer, because cancer patients, if you treat them with complementary medicine, you cannot just say, I give half placebo and I give half. So for ethical reasons, you cannot do clinical trials in this population. And so in particular severe diseases like cancer, where you cannot do clinical trials, even if you want to do clinical trials, it's not ethically possible. And now another thing, and this is an interesting one to mention also here, is we said CAM modalities can have complex conceptual frameworks that are hard to reproduce in an experimental setting. Now, we've had 2 days of workshop about pattern recognition. So in other words, the traditional medicine patterns that you observe. Now that is what I would call a complex conceptual framework that is hard to reproduce in an experimental setting. So again, pattern recognition is a perfect example of where clinical case reports can provide contributions, because you cannot squeeze all these specific aspects that might be relevant from a clinical point of view into an experimental setting. Again, confirmation of something that's already known, specific diagnostic criteria. So the for instance, at the bottom here, there's the patient-doctor interaction. For instance, in homeopathy, there's always a lot of discussion, because they say, well, where is the placebo effect and the non-placebo effect? Because in homeopathy is a very intense interaction between the doctor and the patient, and of course as part of that interaction, the therapeutic interaction in its own right is already contributing to the overall effect. And of course, once we start trying to separate it in this total response, they say, now what is the placebo effect? In other words, what's the non-specific part and what is the specific part associated with the medicine? It's very, very difficult to separate. And again, I've been 2 days in discussions, or 3 days, and it's a very similar problem is there in acupuncture. What is sham acupuncture and what is not sham acupuncture? Big discussions, and but the ritual of interacting with the patients, the ritual of inserting a needle or pretending to insert a needle is part of that interaction. And some of these aspects you cannot capture in clinical trials. So clinical case reports can contribute to a better understanding of some of those aspects. So the second step was a scientific consultation process. So in my case, I did a survey of homeopathic experts, and I established a panel. Well, most of you are familiar with the Delphi rounds. The Delphi process is a well-established method in which you, through several rounds, you're trying to achieve a consensus between experts. And I know here in Korea you've done many Delphis on many aspects of traditional Korean medicine. But basically you have a group of methodologists and clinicians, and also quantitative and qualitative research experts, and ideally people who are not just homeopathic experts, but people who can also bring expertise from other CAM domains. So the objective is to get a very broad mix of people, and then you start with a big shopping list of items that you think may be relevant in clinical case reports of homeopathy, and then you start prioritizing and honing these items down. Again, I don't think you have color in your prints, but basically you end up with providing a score, and if it was more than 8, then it would go into the reporting guideline, because it was generally considered to be important or very important by all. And this is just to illustrate the process that we started off with a whole list, and ultimately what was in the green went into the homeopathic reporting guideline items, and what was in the gray here is ultimately was not included in the reporting guidelines. So these are the included and excluded items in the guidelines. So this work is reflected in a paper which I've submitted and which is now in the final revision stage. It's gone through peer review, and I need to complete final revision, so this paper is probably going to be officially published next spring. And so that would then give us the entrance to the homeopathy specific clinical guideline paper. And what we've done is the analysis and item selection was completed. It was integrated in the care guideline, and in this case I have indulged in publishing it in Complementary Therapies in Medicine, my own journal, but I haven't been involved as an editor in the publication, so we're in the final draft stage now. So the concept of now the reporting guideline where we are is that you have, for clinical case reports, generic aspects. In other words, these are reflected in the care guideline, so they apply to all the cases. And then there's homeopathy specific guideline items, and within that homeopathy specific guideline items we identified a number of core items. These are the ones that you saw green on the screen. They're in the top of the list, and there were still some optional guideline items that were considered important, but the problem was that people said, well, this item is extremely important for teaching purposes, but it's not important for research purposes. So they were the kind of items that were, some people said, no, I don't think, a researcher might have said it's not important, and then someone who's teaching would have said it's very important. So the overall score didn't end up in the top, but it was generally felt that they were optional items, that if you want to use a case for teaching purposes, that you still should consider these items. Now, so how does that work? This resulted, and this is in the paper, is what I call the home case care extended checklist. So the architecture that you see here, the overall architecture, is the architecture of the care guideline, the general one, and what you see highlighted are the ones that we added following the for homeopathy, and as what you can see is that we've added areas in the area of the clinical findings, and that's the clinical history detail, which can be very specific for homeopathy. Then we have the therapeutic intervention, where it was clear that the homeopathy has specific dimensions to the therapeutic intervention, which are important to note, and that can be the description of the homeopathic medicine, how the trade name, the constituents, etc., the manufacturer, the potency. So this is some items specific for homeopathy on the therapeutic intervention. And then most importantly in the end is the assessment of follow-up and outcomes. And the ones that are here is objective evidence, occurrence of a homeopathic aggravation, and possible causal attribution of the changes explicitly addressed and discussed. Now, that's an important one. The occurrence of a homeopathic aggravation, and this is something which I would like to receive your feedback on also today as part of the discussion in the context of traditional Korean medicine as well, is that in homeopathy, when you give the medicine, often initially symptoms get worse, but homeopaths consider that in a majority of cases to be part of the healing process. In other words, it gets worse is a sign that the patient is responding to the medicine, but it's quite specific for homeopathy. But I have the feeling that it may also be relevant or partly relevant in traditional Korean medicine or in acupuncture. So that would be something which I would be personally interested in to get some feedback on. Now, if people have most of you found this checklist, so I don't know if you've noticed something at the top of this checklist. In the title, it says Korean Medicine Guideline Extension Checklist. So I have fiddled a little bit with this, because here you see the home case care extended checklist. So what I have done for the purpose of this workshop is to add or modify some of these items for homeopathy, which I feel might be useful for Korean medicine. And you're all going to participate in the very first pilot study of the very first suggestion of what could be a possible Korean medicine extension of the CARE clinical case reporting guideline. And so you're all going to contribute and participate in the development of that checklist. And so just to take you through clinical findings, is I6K. If you go to topic 6K, I'm saying clinical history detail, and I inserted here Korean medicine clinical reasoning, including PI, pattern identification, used for decision. So this is just the first draft, but the whole idea is following also the kind of work you're doing, that definitely in the case of Korean medicine that should be is a strong suggestion to have that in your clinical case reports. And then we go to to 6. Let me just check. Yep. So then we go to 9, the therapeutic intervention. And here, so 9K1, I turn it into a K to give the hint it's from the Korean medicine edition. It's type of Korean medicine. Now actually that's a typo, the individualized formula, single multi-constituents, isopathy, sorry that's a typo, that's still from the homeopathy one. So ignore the isopathy part, but I understand that there are different schools in traditional Korean medicine, so it's a little bit about if there are different types of schools, then which one was used. And 9K2, in particular the treatments, the herbal products, the names, the sources of the herbs, and of course for acupuncture it's a little bit easier because acupuncture have developed a stricter guideline to describe the acupuncture intervention. So this is where you would borrow from the stricter guideline and insert detail on the nature of the intervention in line with that existing guideline. And then the 10, the follow-up and outcomes. At the bottom you see 10K1, objective evidence if available. Again, in homeopathy we definitely felt that it was very strong, that a case can be made stronger by having objective outcome measures as far as possible. It doesn't mean that non-objective or subjective outcome measures are not useful, but the vision, it was generally felt that if you have objective outcome measures, that is added value. Now, then we go to the back of the page, and then you see 10K2, and that is the possible causal attribution of the changes is explicitly assessed and discussed. And this is a very important topic because, of course, the main criticism of the conventional evidence-based medicine people is that they say, well, a clinical case report can never give you a statement about the cause and the effect because there's no control group. And so, but that doesn't mean that, depending on the case, that, and that is true. I mean, a single case report is unlikely to give some definitive proof of a causal effect. So it's not, it is true, but a clinical case report can be a stronger case. In other words, on the basis of an assessment of the changes that you observe, there are certain principles and criteria that you can apply to say, well, it is more probable or less probable that the changes that you actually observe can be attributed to the treatment. Now, this is an extremely important and complex topic as well. So, so what you see here is the world premiere of possibly the very first Korean medicine draft of the first Korean medicine extension of the care reporting guideline. So we'll get back to this one when we do the practical exercise. So what I already mentioned is the likelihood of causal attribution, and in this case to homeopathic treatment. There's a topic on which we've worked with a team of experts now, I would say for the past decade, in the homeopathic community, different people have worked on it. And personally, I have worked on a project on this with a group of homeopathic experts for the last 3 years, and we've tried to develop criteria that are useful and meaningful to use in practice. Now, so it's one of the core homeopathic items, and it's also one of the core items in what I propose for the traditional Korean medicine. Now, to date, this was mainly done at face value, and what I mean with face value is that people made kind of gut decisions that, based on their clinical experience, that you would say, well, as a clinician, I've seen a lot of patients. You give something and you expect a certain change to see, and if you give the medicine, you see something which is much more dramatic than what you would expect on the basis of your clinical experience. So that's a gut feeling. Now, that gut feeling is a good thing, and of course, through experience, every clinician will develop that gut feeling. But of course, when you want to compare and when you want to get a transparent line of reasoning, as I mentioned, you need to try and develop criteria which are transparent, which people can agree with or disagree with. So this is Dr. Lex Rutten. He initiated a project. It was about 10 years ago, where he's a homeopath, so he started by looking for if there's anything in the area of conventional medicine, and he found 2 lists. The WHO has a list for the assessment if there's adverse drug reactions, and so obviously in every clinical trial that you do, there's always the ADR form, which consists of a number of items that you assess that will help the clinician to assess, well, what's the likelihood that this adverse drug reaction is due to the substance. And so the WHO developed a questionnaire for that. But another person called Naranjo, he further elaborated on that. And then Dr. Lex Rutten said, well, these criteria are mainly for adverse drug reactions. Some of these criteria are useful for homeopathy, for therapeutic potential reactions, but other criteria are clearly not useful. I mean, there are some specific dimensions for homeopathy that homeopaths consider important, and so this is what we've modified that and refined that. And this was done in the context of the HPUS. The HPUS stands for the Homeopathic Pharmacopoeia of the United States. And I'm a member of a committee that reviews the clinical data for when homeopathic companies want to submit monographs for their products. There are certain requirements. And this pharmacopoeia reviews the clinical data, and so I'm part of a team of experts that is developing and reviewing the clinical data for these homeopathic monographs. This working group, we're working on the topic of clinical case reports, because it is anticipated that clinical case reports can be part of a monograph submission for homeopathic medicines in some cases. And so we realized that we needed criteria to assess these cases. And so what's resulted in that is what we call the modified Naranjo criteria. These are 10 criteria which we developed for homeopathy. They're associated with a score. And what you can see, something adds up, and something means a deduction if it's a no. Now, for instance, here, did the clinical improvement occur within a plausible time frame relative to the drug intake? In other words, you take a drug and you would say, well, after 3 months the complaint got better. Might not be an entirely convincing case, and so. But of course, it's a plausible time frame. In other words, for an acute case, a plausible time frame could be minutes. In other words, that you say you see an immediate response. Whereas in a chronic case, a plausible time frame could be weeks or sometimes even months if it's a very, but it's based on this clinical aspect of clinical judgment where it's a plausible time frame. Now, if it's a yes, then you get some points added. But if it's a no, we actually deduct something. So the reasoning behind it is that some information is neutral. Now, for instance, I spoke about this topic of initial aggravation. In other words, the symptoms initially get worse in homeopathy. If it's a yes, we say fine. That could be an indication this is a homeopathic response to the homeopathic medicine. But if you don't have it, and because the expert said yes, but not all patients have initial aggravation, so it wouldn't have been fair for us to say there's an aggravation, you deduct points. So if it's there, you get some additional points. Now, a very important one is, are there alternate causes? Let me just check it. Are there alternate causes other than the medicine or the treatment that with a high probability could have caused the improvement? And related to the known course of the disease, it could have been other forms of treatment or other clinically relevant interventions. So what you can see here is that if there is a reasonable argument that there could be other causes, you get a -3. So this is a very heavy weight has been put into this aspect. So it's a very important consideration, and the nice thing about this checklist is that it gives you some handle on it makes the thought processes that you have to go through when you try to assess the likelihood of a causal reaction explicit, so it helps you with that. And what I've done, but I'll show that before we do the case, I've slightly modified this also because some of these things are relevant only for homeopathy. So before we do the case in a few minutes, I will take you through a few things to think about for traditional Korean medicine as well. But I don't have an official slide because it's not really developed yet, but at least I want to give you some hints what might be relevant in your context for this list. Right. How are there any questions at this point in time? Yes. Are there microphones or? Sorry, they're getting the microphone.
I wonder how can decide the scores, different scores for each items. I think.
Yes, I mean sorry. Yes. I mean, what we have developed here is in the context of, as I mentioned, a committee of the Homeopathic Pharmacopoeia of the United States. That I mean, in the original Naranjo criteria, there are similar scores. So some of these scores have been inspired by the Naranjo criteria, but of course there are some specific homeopathic aspects, and so the overall scoring is like a new development. And with someone in India now, we're going to in the coming years to further validate it. So these scores need to be further validated in the context of homeopathy. And so for me, in a way, these scores are slightly less important. The total score is to a certain extent less important. What I really want to communicate is the thinking process, the fact that you go through these steps and that you get some sense of, okay, do I have a lot of pluses or do I have a lot of minuses? If you have a lot of minuses, you should be much more cautious. in your conclusion. If you have a lot of pluses, you can feel more confident in your conclusions. At that level, I think we should apply it, and the actual scoring is something that will still need further validation. Right, I think...
Yes, thank you. Just one, in one of your slides, you were talking about the expert groups and the Delphi issues around that. And I heard you speak the other day, so just wondering, in terms of the expert group, how do you deal with confirmation bias in those kind of groups?
And you mean, can you give a concrete example, confirmation?
No, I mean, because I feel that having a Delphi group is a sort of a close discussion group where you have anonymously people can respond to you, but I think if you have a group of experts, then the voice of one expert will be the issue. They all discuss. I just wonder, have you had any experience in how you can deal with those issues in terms of having an expert group compared to anonymously the Delphi process?
Yeah. Well, I mean, this was a modified online Delphi, so at least people came in it. They didn't know what the others were doing when they came in with their own comments that might have provided some warranty. I think the other thing is, of course, how carefully do you select your experts? If it's really a limited group, there is the bias caused by the group that you would select. I mean, what we did is the expert group was about 20 people, but then we went through. We confronted a broader group of homeopaths also with these criteria. We did already a small pilot study in India where we compared even the perspectives of Indian homeopaths with the US homeopaths. And so I would say it is a gradual process where you start triangulating the information with other sources of information to reduce and maybe take away some of that aspect, yeah. I think maybe it's a good time to have a short coffee break. After the coffee break, I'll say something about critical thinking. Then we do the exercise, and then after the exercise, we have a conclusion and roundup session. Thank you very much.